Clinicomicrobiological profile of microbial keratitis in a tertiary care center in Eastern India by Dr. Smriti Ranjan. Anjalika. Sorry.
Good morning, one and all, respected judges. I am Dr. Anjalika Padi. My topic is Clinicomicrobial profile of microbial keratitis in a tertiary eye care center in Eastern India. Corneal diseases are among the major causes of vision loss in the world today, second only to cataract. Microbial keratitis is infection of the cornea caused by a wide spectrum of microbial agents. Though the clinical signs help us in distinguishing the various causes of microbial keratitis, the etiological agents of microbial keratitis vary considerably between continents, countries, and also within the countries, depending on the geographical area, climatic condition, and host factors. We did a hospital-based observational, prospective, and clinical study in which we took 152 cases over a period of 1 year. All newly diagnosed cases of microbial keratitis were included in our study. However, children below 18 years of age, pregnant women, one-eyed patients, scleral involvement, impending perforation, desmetocele, concomitant endophthalmitis, and suspected viral ulcers were excluded from our study. Data collection was done and clinical evaluation was carried out using slit lamp and B-scan wherever required. Diagnostic procedures like corneal scraping, direct microscopy, bacterial and fungal culture, and antibiotic susceptibility was carried out. Bacterial culture was said to be positive if there was confluent growth at the site of inoculation of one media or there is growth in one media consistent with direct microscopic finding. Fungal culture was grossly identified by its colony morphology and pigment production. Antibiotic susceptibility pattern was carried out using Kirby-Bott diffusion method. Coming to the results, the most common age group of presentation in our study was 41 to 50 years of age. Male showed a higher preponderance. Most of the patients were coming from rural area and they were most commonly involved in agricultural work. More than half of the patients in our study presented to us within 1 to 7 days of onset of symptoms. History of trauma was present in 73% of the patients, and vegetative matter followed by trauma with soil, sand, and stone was the most common type of offending agent. The most common ocular risk factor were eyelid abnormalities followed by dichrocystitis, and diabetes mellitus was the most common systemic risk factor. More than 76% of the patient had already put various topical medication before coming to our center. The gram stain positivity was for bacteria in 45 cases and positive for fungus in 57 cases. KOH was positive for fungus in 95 cases. Bacterial culture was positive in 34 cases and fungal culture was positive in 68 cases, and 5 cases showed positivity for bacteria and fungal both, and they were classified as mixed infections. The most common fungus isolated in our study was Aspergillus flavus, followed by Aspergillus fumigatus, and the most common bacteria found was Staphylococcus, followed by Streptococcus. The antibiotic susceptibility of various bacteria was found. These are the McConkey agar plate showing Staphylococcus and Aspergillus and Fusarium. Coming to the discussion, our sample size was relatively higher compared to the other studies done in the geographical area. The mean age group was 43 years and males were most commonly affected in our study as similarly seen in other studies. However, in a study done by China, Cao et al. In China, females were most commonly affected, probably because of higher employment of women in the agricultural sector in their part. The most common ocular risk factor in our study was entropion. However, in a study done by Patty et al. In Eastern India only, dichrocystitis was the most common risk factor. Our culture sensitivity positivity was relatively high compared to other studies. We found that fungal keratitis was more common than bacterial keratitis, which is in contrast to the finding done in Eastern India by Patty et al., where bacterial keratitis was more common. Staphylococcus was the most common bacteria, which is similarly found in other studies. However, among the fungus, Aspergillus was more common compared to Fusarium, which was found in Eastern India. So I would like to conclude that due to the diverse clinico-microbiological profile of microbial microbial keratitis, the adoption of empirical therapy cannot be reasonably supported. Hence, a multi-pronged approach like meticulous clinical examination, early establishment of the etiological agent by microbiological workup, timely initiation of susceptibility-guided antimicrobial therapy can prevent emergence of resistant strains, reduce morbidity, and drastically improve the visual prognosis and quality of life. Thank you.
Thank you very much. In which part of country this study was done?
So we did in Odisha, eastern part.
Okay, so you found the most common microbiological pattern of bacterial or mixed?
So fungus was more common than bacteria.
Fungus was most common, followed by?
Bacteria.
Followed by bacterial.
Yes, sir.
And amongst the organism?
So-
Staph.
Yes, sir. Staphylococcus was more common than Streptococcus.
Which staph?
So aureus.
Aureus.
Yes.
Okay, and in fungi?
So fungal we got Aspergillus flavors followed by fumigators.
All right. Any viral?
Sir?
Viral.
Sir, we excluded viral ulcers.
Okay,
Any
thank you.
correlation between diacrocystatis and bacteria? Which bacteria you found?
Ma'am, we found most commonly it was with Staphylococcus.
Even in diacrocystatis?
Yes.
So, Dr. Anjalika, out of the 150 odd patients that you've screened, how many were microbiome positive?
Ma'am, 70.4%.
So, almost half.
Yes, ma'am.
And you had excluded patients with impending perforation. Any particular reason?
No, ma'am.
Okay. And did you find any parasites like acanthamoeba or pythium or any other?
No, ma'am.
Thank you.